who I've seen before, and I want to thank Jerry over here who made me a, Jerry, what is exactly this? This is the, it's a keychain, but it has some significance of being an S?
No, letter G.
Oh, the letter G. Okay, so I don't know how that represents G, but maybe some of you do, so, oh, I see, okay. Well, my name is John Schofield. I'm an ophthalmologist, and I've been in this region since 2005. And I know some of you from days gone by, and some are familiar faces. And my practice has kind of changed a little bit over the years. And I don't know, I'm getting a little bit of feedback on this. I don't know if people are getting that. I have two staff members here I want to introduce to you. If I've got Sherry. Come on, make you stand up, Sherry. That's Sherry. And this is Teddy. Hi, Teddy. And so they're helping me out with the office, where we recently changed exactly where I'm located on El Paseo Drive near Portola. There's a post office by there. And so that's where I am now. Some of you may have expressed that you cannot find me because there's been some flux in the transportation to getting to where I'm at, and because some of you I may have seen before at the USC satellite office we used to have out here, and maybe some of you remember Dr. John Hodgkinson, who passed away. It's been 2 years now, and then when he did, we kind of had to move the offices from the Rancho Mirage location, and now we're in Palm Desert. So that's where we're at. I may have seen some of you at another location with vision professionals in their outfit, either in Palm Springs or in Palm Desert, and so wherever I've seen you, or if you're new faces, welcome, thank you, and all. So very good. So today we're going to talk about just some topics about the eye. We can talk about anything you want to mention, anything you want about the eye. I specifically wanted to discuss with you some things concerning glaucoma and concerning maybe some macular degeneration. Those are probably the primary things that bring people to this institution. And I want to thank the people here at Braille for welcoming me and bringing me here. And I know I've had to reschedule maybe once or twice just with my schedule. So anyway, how many people here use some form of eye drops or been told they have some sort of eye problem that they need treatment for? Is that pretty much everybody here? I see some people, Dell hasn't raised his hand, but he's got glasses on over there. So somebody told me he needs something for his eyes. So eventually at some point, everybody has something happen with their eyes. I was fortunate enough not ever to need glasses, but now as I am in that age when things up close are not quite as clear, so I'm doing this. And so you don't get out of this without having something happen with your eyes. Fortunately, that's a pretty easy fix with some reading glasses. I'm sure many of you experienced something like that. We're kind of just going to show a cartoon here about the eye and the anatomy and so forth, but we're going to switch out the projector because it's doing whatever the projector and the camera do together. Yes? Sure. Sure, okay. Yeah, dry eye is a huge topic here, lo and behold, we're in the desert. So you can imagine that's probably a very common topic. But even in areas which are not dry, in the environs, dry eye is a problem. And there are many, many, many over-the-counter solutions and so forth. Well, hello, Donnery. How are you? Blast from the past there. Okay, so there are many, many over-the-counter solutions. There is one prescription medicine for dry eye called Restasis. Specifically, the question was about what dry eye solution or drops that you may use which don't have, what did you call them, all those crazy chemicals in them?
Unnecessary chemicals.
Unnecessary chemicals. Well, I think what you might be referring to is preservatives. And there are preservative forms of eye drops. They almost always come in these little single-use vials that you use them and you clip the top off and you put a drop or two in and you toss that away. Sustain has a product like that. Refresh has a product like that, and they are all over the counter. But if you want to get the preservative-free one, they always come in these little single-use vials that you throw away after using it. And with dry eye, there are lots of behavioral things that you can do to help with dry eye. How many people feel like they suffer from dry eye at times? So yeah, we see a lot of hands going up. And people, you use the over-counter drops? Yeah. Which ones do you use? Do you know? You've used Sustain and Blink. So these are common names. Optic, Refresh. There are a whole bunch of them out there. And they all are available, like I say, over the counter. Some of them cost quite a bit of money, if you haven't noticed. So whenever you're coming in to see the ophthalmologist, make sure you get a sample of those or get a coupon or something. They're all very similar in what they're trying to do, but they do have different approaches. Some of Sustain, just within Sustain, there's drops which are kind of light, and then there's ones that are a little bit heavy, and then there's even gels that you can use. And in certain situations, some are better than others for people. So, but if you are looking for something with a preservative-free, then it always will come in that individual packets, Bibles and so forth. How are we doing, buddy?
In surgery.
Okay. Yes, sir. What's your name? What's your name?
Prosthesis?
Yes.
Is that something or that good for a period of time? And the next part of that is, does that actually open up something else?
No. The question had to do with a prescription medicine for dry eye called Restasis. They advertise this on television, so you may have seen that. Does anyone here take Restasis? Donna tried it. What's your name again? Oh, Harry. Oh, Harry. And so some people have tried Restasis. It is a long-term medicine. It's actually medicine that helps produce more tears. It does not open up any ducts in the eye or anything like that. It works on the cells on the surface of the eye called the goblet cells to help you produce more tears. So while we're getting this ready to go, why don't we just it seems to be a little bit of interest in dry eye right off the bat. The number one symptom of a dry eye, Harry, what would you say if you had dry eye? What's the number one thing that you come in complaining of? Irritation. How about you, Donna? With dry eye, what do you get? Feels like sandpaper. Sandpaper, tearing, redness. These are common things that we see with people who have dry eye. Now, well, what wets your eye? Your tears. Well, your tears are not actually just water. There is actually a couple of things that come together to make a nice, healthy, natural tear film. And there's basically three components to that. One is a lipid layer, which is kind of like a fatty layer. One is called mucin, and one is a liquidy, watery layer called there we go. Awesome. And I'll get it from you. So those three components come together to make healthy tears. What happens in many people is that they'll get a dry eye. They'll come in and say, "My eye's watering. My eye's watering." And the doctor says, "Oh, you have a dry eye." Now that doesn't make any sense at all, does it? No. Okay. So what that is, though, is your eye is responding to the lack of the other components in the tear film, and it tries to flood it with the liquidy aqueous component to it, and then you get a watery eye, which is actually a symptom of a dry eye. So the use of the artificial tear, even if your eye is tearing, helps to stabilize your dry eye and help it tear less. Restasis is a prescription medicine which is called cyclosporine, which many of you may have even heard that medicine, may sound familiar. It's actually a cancer medicine, but it's in a very, 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 very low dosage, and it only stays on your eye. And it helps to produce more of that component from called mucin, and it helps the tears that are on your eye stay on your eye. So you don't want your eye to be like the back of a duck. When the water hits it, beads up, and rolls off. You want it to kind of stay on there and make a nice film. And so the more mucin that you have, and the more lipid that you have from the other components, it'll keep the watery portion of your tears staying on there nice smoothly and not evaporate right away. And so Restasis is a good medicine. It is used, though, and does not get its effects immediately. The Restasis you take, it's like saving for retirement. The Restasis you use now helps you months down the road. Okay? So don't expect Restasis to make your eye feel better instantly. That is something that will come about with time. And you still need to use artificial tears at first, but what happens is your use of artificial tears gets less and less. Right. Well, let me see here. Sometimes this is on, sometimes it's off. I don't know. So let me just key up some of this information. We're going to talk a little bit about glaucoma, and I'm going to be going back and forth from this computer screen here. But let me see what I got here. Well, this looks like somebody's doctor's office, and we're going to talk about what glaucoma is. And I know there's several people in the audience who have glaucoma because I've either seen them before or done surgery on them. And what's happening to this person's vision here is they're looking at these wedding albums and these pictures of their children, and they can still see them clearly, but it's getting dark all on the outside. And it's getting darker and darker. The center portion, though, is still clear until eventually that can go. And then that is how glaucoma affects people. What happens is you start to lose vision, and it's not painful. And that vision loss comes from give me 1 second here. That vision loss comes from damage to this structure we're going to talk about right here called the optic nerve. So glaucoma is a problem where people lose the optic nerve, which is the connection from the eye to the brain. Your optic nerve is actually not just one nerve. It's about 1.5 million little nerves which all join together from your retina, which is structure, we'll go over all the anatomy a little bit more, and connects to your brain. And when you lose the optic nerve, you start to lose, usually at first, peripheral vision around. And it's painless, and it's not very noticeable at first. And eventually, you lose more and more of the vision until your central vision is dramatically diminished. I know there's some people here in the audience who have experienced a very profound loss of peripheral vision from glaucoma, and it is something that is, we call the sneak thief of sight, because it's painless and it's very asymptomatic until it is quite advanced. So, what you're looking at here, let me just pull this back. What you're looking at here is the eye. We're going to go in through the pupil and look to the back of the retina. I don't know if you're kind of familiar where I'm at here. You saw how we went through the pupil, and now we're on the back layer of the eye called the retina. Well, right in the center of the retina, there's this yellow kind of disc. And I don't know if you can see that, but I'm kind of circling this yellowish disc. That is called the optic nerve. And what that does is it takes all the signals from your retina, which is that whole big orange thing, and the red things are blood vessels on there, and it sends that information to the brain. Now this looks like a pretty healthy optic nerve because the little inner whitish, yellowish, very light yellow part is very small, and that's typical. That's kind of called the cup. Some people will say, oh, I had cupping of my optic nerve, and they weren't sure what they were talking about. Why did the doctor say I was having cupping? Well, they're talking about enlargement of this space called the cup. And everyone has a little bit of a cup, but it gets bigger with loss of optic nerve. And what the cartoon here will show you is that optic nerve, then right in the cup there, if you lose it, if you start to lose the symptoms from that, the symptoms look like this. You're looking at a picture of your grandkids here, but you'll notice that off to the sides here, you're losing peripheral vision, even though you can still see some of these things quite clearly. Some people can have very, very advanced glaucoma and still be 20/20. Now, what the heck is glaucoma from a different standpoint? Well, it has to do with pressure, and I'm going to talk about that right now. In your eye, your eye develops a pressure. And where does that pressure come from? And so forth. I'm going to just skip this one here, and it damages the optic nerve. And it's showing you here a high pressure, but I think there's a better cartoon on the next one, and then it shows you again how you lose vision. So let me just go to the next little thing here. And it has to do with how fluid circulates in the eye. So here's the eyeball, and now we're going to kind of look at it from the side. Is everyone trying to see where we went there? This is the front of the eye. The back of the eye was here. This is your iris. Here you got where we're at there. So there's a fluid circulation which occurs in your eye. It's normally supposed to occur like that. And it's with this fluid called aqueous humor. It's the only place in the body that this fluid exists. And it comes from a gland right behind your iris. So if you look at your friend there, they got a blue eye, or they got a green eye, or they got a brown eye from the iris. And right behind it is this gland. And that gland produces this fluid called aqueous humor. And that fluid drains behind the iris and then out of this thing called the trabecular meshwork. And then it gets picked up by your blood vessels. And that circulation is where the pressure comes from in the eye. So this cartoon here is going to focus in on that ciliary body. And it's producing this fluid called aqueous humor. And then that fluid will drain behind the iris, forward through the pupil, and then out of this area called the trabecular meshwork. And that's blown up there. And that fluid then goes through that meshwork and gets picked up by the blood vessels. And this circulation of fluid is important to the health of the eye. However, in some people, that circulation is problematic, especially with the outflow. And so, but this creates a pressure in the eye. And this is kind of the green. Green is good. But in some people, that fluid circulation will no longer be appropriate, and the eye pressure will go up. And I think that's where we're going to go to next on this little cartoon. So we're going to talk a little bit again here. We're in the front of the eye, obviously. This is the cornea. This is the iris. This is the lens. This is the retina, and that's the optic nerve, that thing way back there. And again, the fluid is going to be produced here by this ciliary body, flow like this, and then out of the trabecular meshwork. And that's what they're highlighting here, is that trabecular meshwork. And again, so this is the trabecular meshwork. Some of you here have had laser done by me on that trabecular meshwork, and it helps to reduce pressure. So in this situation, there's an angle, and this angle is open. And some people say, do you have open or closed angle glaucoma? Well, this is an open angle we're talking about. So the circulation of fluid goes, it goes out, everything's fine. But for some reason, this stops working so well, and the pressure goes up. And when the pressure goes up, it starts to damage the optic nerve, and you start to lose them individually. And there you are sitting at work. I can still see my computer just fine, but I can't see over here so well anymore. I can't see down here so well anymore, and so forth. And then you start to lose that. There is another type of glaucoma. Well, there's several types, but then we're going to talk about this when this angle gets narrow. And again, this angle right here between the iris and the cornea, that can actually physically become more narrow as the iris approaches and touches the cornea. And you can get what's called angle closure glaucoma. And that's quite problematic, and you can lose vision quite quickly from that type of glaucoma. I'm going to show you the fluid circulation again from the ciliary body. But now you see how that iris has kind of created this angle, which is narrow? Well, what happens is that's like closing a couple lanes on the highway. Traffic backs up. And when that traffic backs up, that's the fluid backing up, it makes the pressure go up. And this can be very problematic in that it can go to a form where it completely closes. And if it completely closes, then you have what's called angle closure glaucoma. A true emergency, you can lose vision quite rapidly. We have to do an emergency type of laser for that. The vast majority of glaucomas are the first part, the primary open-angle glaucoma. This is talking about someone who has this angle closure where it closes right off, and I have to do an emergency type of laser. How many people here take glaucoma medicines? I know a few of you. Okay, so it's quite a bit. You put the medicines in. Why do we put the medicines in? What do the medicines do for us? Do you know? You just because the doctor told you? So take the medicines. Helps to keep the pressure down. That's right. We want to lower the pressure of the eye. And why do we want to lower the pressure of the eye? Because the pressure damages that optic nerve in the back of the eye. This is kind of a cartoon showing the pressure hitting that optic nerve. And if we lower the pressure of the eye, then we can help save what vision you have. Unfortunately, it doesn't restore vision that you may have lost. When you lose vision from glaucoma, it's permanent because of nerve loss. Well, here you are in your bathroom. Somebody said, take these eye drops. Harry was over here taking his Restasis. And how many times have you taken a drop and you felt like you got more of a bath than you got an eye drop, right? So here's some ways to apply drops, and I can go over this a little bit, but the cartoon shows you that the best way to put an eye drop in is to pull your eyelid down and create a little pocket down here and try to apply it. If you have someone who can help you do it, that's even better, because it's good to have friends, and they help you remind you to do it. And you put the drop in, you can close your eyes for about a minute afterwards. Some people like to hold pressure in the corner to try and in what's called a punctum. So if the medicines taste bad, and so forth, you can decrease them going down the back of your throat if you hold a little pressure in the corner of your eye after you apply them. So, so here's the eye drop. I don't know, eye clean. That's not a real eye drop. It's just a cartoon. So let me just see where this goes next, and then I'm just going to discuss a laser, and then I'm going to kind of overview here. There's a laser. I've done some laser on some people here for laser for glaucoma, and it's called SLT. We do it in the office, and it works on it stands for selective laser trabeculoplasty, and it works on the trabecular meshwork, which is this area where the fluid flows through. And what it does is we apply an energy beam in the form of a laser to the trabecular meshwork. It takes about 3 or 4 minutes to do, and it helps it work a little bit better. And so I don't know, has anybody had SLT here? I think some of you may. We did, Barry, we didn't do SLT. We went right to surgery with you, right? And so they're just talking about some of the lasers and how we do that here in the office. So what I kind of want to do here is I want to kind of back it up. I kind of went over a lot of topics, maybe lost a couple of you, which is okay. You don't have to, we're not trying to make you an ophthalmologist. But, you know, this seems to be cutting in and out. I don't know if it's more problematic if I just talk, if it's better. Oh, you got a replacement trade. Yeah, because it's kind of cutting in and out. So let me just do this. I'm going to back up, and I'm going to talk about glaucoma just a little bit, but I want to go to just this cartoon again here, hit play, and just to give me something to point to, and then we can kind of go from there. So here we are, the eye. There's the optic nerve, and go from there. Okay, give me 1 second, and I'll address that. Next one here. All right, this is a good video right here. So what I'm going to do, I'll address that directly in just a second. So when you come in to see the ophthalmologist, what do they do? Well, have you sit in the waiting room and wait. That's why we have waiting rooms, right? Have you sign charts, have you sign papers, ask if your address has changed. Anything changed with your insurance? We got to make 17 phone calls. Oh, and then, by the way, we get to see you. So that's kind of the nuts and bolts and logistics of going to see the doctor, which I'm sure is a little bit frustrating for everyone. But then you come in, you see the ophthalmologist, but you usually don't see the ophthalmologist first. Usually you see a young lady who will check your vision, right? They put that thing over your eye and you go, oh, E, C, D, whatever. Is that an O or a D? I'm not sure. You do that. That's called your visual acuity. And that has to do with how clearly you see. You've probably heard of something called 20/20, which stands for 20 feet over 20 feet. That just basically is telling us that the normal human eye can measure or resolve, see up to, at 20 feet, a certain size letter. Okay, that's all that means. If the number is 20/50, that means the letters have to be a little bit bigger for you to see them at 20 feet. The next part they do is they always say, okay, let me look at your eyes, let me put these yellow drops in your eyes. Have you had the yellow drops in your eyes? You're like, why is this guy putting mustard in my eye? And why is he doing that? Well, the yellow drops are so I can check the pressure. And what they do is that's a combination of an anesthetic, called lidocaine, and then there's something in it also called fluorescent, that's the yellow portion. And then they turn that blue light on, and they come at you with that thing, and you say, whoa, what's this thing, is it going to stick me in the eye here? And that's how we check the pressure. Harry asked me a question, he said, what's the heck's that puff of air? You probably had the puff of air. Boom! The puff of air is also checks the pressure. It is called pneumatic tonometry, because pneumatic, like pneumonia, means air, lung, breathing. And so it's just another way of checking the pressure. It is not quite as accurate, because what's the first thing you do when you go in there? You go, people say, are you going to do that puff of air? And they're grabbing the sides, white knuckling, right? And they're not happy. And you can make your eye pressure go up just by squeezing a little bit, just for that moment. And so it's not typically a very accurate way to check the pressure with the puff of air. But it does work, and it's used. I don't use it in my office. What I do, and most ophthalmologists will do, is we'll put a drop of the mustard, the yellow stuff on your eye. We'll bring that little blue light thing that comes and touches your eye, and that evaluates the pressure. And some people take drops to lower the pressure. So when you go see the doctor, they say, okay, you got glaucoma, take this eye drop, see me in 2 weeks, see how you do. And then you come back and you go, I'm awful, my eye's red, it's irritated. And I check and you go, hey, but your pressure, you're great. You say you're awful, I say you're great. And why is that? It's because I'm checking the pressure, and the pressure may have gone down. You may have started at 26, you may have started at 20, you may have started at 35, you may have started at 50. Pressure ranges, and I'll go over what the normal pressure is in just a moment. But then you use this eye drop, and it lowers the pressure. But you don't see any better. You don't really feel any better. Sometimes you feel worse because the eye drops hurt, or they cost you a lot of money. So always ask for a sample, and always get like a coupon if you're for some of those medicines, that some of them that come with the manufacturer's coupon also. So, but it lowers the pressure, and that's what we're trying to do with the treatment of glaucoma, is lower the pressure. And we almost always start with eye drops, but there are other forms of treatment, like I briefly showed with the laser, and then there's also some surgical interventions. You use the drop, it lowers the pressure, now what? Now we say keep doing it, and you keep doing it. And so the goal for glaucoma treatment is to keep you seeing as well as you saw before you came in. It doesn't make you see better. It's not, it's not something where we take a bandage off, like after I do cataract surgery or something, and go, hey, wow, I can see a lot better. Okay, the treatment is a much different goal and a much different kind of problem that we're treating than something like a cataract surgery. And we'll discuss cataracts in just a bit. What you may also experience at the doctor when he's checking you for glaucoma is he may stick your head in a big thing, looks like you're going into space, right? And he tells you to push a button. And what do you say? It's Pat and Pat, right? Or is this your Pat? This is Helen. Phyllis and Phyllis. Okay, we got Phyllis and Phyllis, we got Pat and Helen and Helen's. The guys are teaming up on me here. So Phyllis, you put your head in that big thing and you push a button when you see a light. And what do you say when the doctor says, oh, I think we got to do that test on the visual field? Yeah, this is what exactly everyone says. This is exactly what Phyllis said. Oh, gosh, not that test, that visual field test, really? Well, what are we doing when we do that test? We're checking your peripheral vision. Remember when that optic nerve got damaged? Where was the problem? Where did you lose vision? Often the periphery. You could still see 20/20 sometimes, unless it gets very advanced. but that peripheral vision. So that test is a little bit, well, not fun, I'll just say that. But it does give us a good indication of where you are, and that's called the visual field test. There may be some other special pictures that are taken where you kind of see these lights and so forth, and what those tests are doing usually is something called OCT, which is a test which measures your optic nerve and how much you have with a computer model and so forth. So yeah, oh gosh, that's right, you take that test. So hang in there when you take it, because the better you take that test, the better that the doctor knows how your glaucoma is doing. Because if you take the test and you go, I hate this test, and you just don't pay attention, it doesn't give us really any information. We can tell if you've done that or not too, and we won't scold you, but you know, you're kind of limiting how well we can help you too. A lot of times I'll say to patients, hey, you did a great job. We did the surgery, and you're putting the drops in, or we did the laser, or you've been using your drops, you did a great job. And they'll try and pat me on the back and say, no, you did it all, doctor. You think, not really. You walked in, I said, yeah, this is your situation. I said, use these drops. But you're the one who's got to go home and put them in, or tell your husband or your wife to put your eye drops in and deal with getting them at the pharmacy and so forth. So really, you guys are doing all the hard work of getting that drop in your eye. And getting the drop in is a challenge. And you know, it's not just getting them from the pharmacy, and when you go there and they tell you, oh, you can't get a refill for another 3 days because of something with your insurance, it's very frustrating. Yeah, exactly. Yeah. So a couple of long-term patients here, Barry and Donna here, are telling me that, yeah, I go to the pharmacy, I go to get my refill of medicine, they tell me you're not due for a refill for a week, so thanks for coming down to CVS, but come back in a week. But you know, by all means, buy candy bars and toilet paper or whatever you need from the store too. It's kind of why they want you to come back and forth too. A little bit of foot traffic in the pharmacy. But anyway, so getting the drops in. So you guys are really the ones who are doing the hard task. What you got?
When you put the drops in and you didn't quite get it right.
Sure.
You just think a small amount went in.
Yeah.
You put a drop in, then again.
Great question. Let me repeat the question. It has to do with when you put your eye drops in. It's a tough thing to do. You got to sit there and figure out a way to do it. Some people have all these different ways, and I'm going to tell you what I usually tell people on how the best way to get drops in. But if you miss a drop or you're not sure it went in your eye, just try to reapply a drop. You will not overdose on the drop, okay? But it's kind of expensive, these little things. Maybe you notice that. And so a way that you can be kind of frugal with your drops and make sure you're getting the bang for your buck is one thing that you can do is if you're unsure if you're getting your drop on your eye, is you can put your drop in the refrigerator. And it'll just make it cold, obviously. You don't want to freeze it, but you just want to make the drop cold. That way, you'll know it hit your eye, as opposed to maybe you hitting your cheek. So that's one way to just get some kind of feedback from the drop hitting your eye. Oh, it's cold, it's definitely on my eye. And if you feel that, you got enough of the drop in. If another thing that you can do, the best probably way that I tell patients to get the drops in is to either look in the mirror, pull your eyelid down and place it in like they showed on the cartoon there, or just to lay down flat and pull your eyelid down and put the drop in. But what you want to do is you don't want to do this, this bombardier thing. You don't want to do this, kind of get it in this eye and you're dropping it from up here. You'll almost never hit the eye. It'll go all over the place. So what you really want to do is maybe use 2 hands. If you don't have somebody who can help you do it, that's the best thing, to have someone help you do it. But if you're putting them in yourself, you want to use 2 hands. And I'm going to show you here. Winnie, could you hold that for me? So probably the best way to do it is if you got the drop in your right hand, and you take your left hand and you pull your eyelid down, you're laying down in your favorite chair or something, and you use that as a fulcrum, and then you take your other hand and you kind of rest it on that hand so it steadies it. Then you can get that drop in. If you try to do this, it's very, very difficult. You may get lucky and get one in, but you'll probably miss about half the time, if that. Yes?
Can you explain what the drops are, what the chemical is, and what it does?
Sure. And it lowers the eye pressure. Right. And so eye pressure and blood pressure are two different things. Does anybody here take blood pressure medicine? Everybody, right? So, blood pressure and eye pressure are two different things. Your blood pressure has to do with your heart and your blood circulation through your arteries and veins. Your eye pressure has to do with that special little circulation we talked about in the front of the eye with that fluid called aqueous humor. And what the drops do, there are several different types of eye drops, number one. And within each of those classes, there are several different medicines within the class for each of them. But all the drops do is work somehow to lower the pressure. The most common drop that usually is started on is something that you use at night. What do you use, if you don't mind me asking, for your glaucoma? Okay, so it has a yellow top, I bet. Yeah. Yeah, it does have a yellow top. It either has a yellow or a blue top. The blue top is 0.25%, the yellow top is 0.5%. Okay, so almost always, they're not very often have the 0.25. So that's timolol. That's what's called a beta blocker. That medicine's been around for a long, long time. And now it used to be the gold standard for glaucoma as the initial treatment. We see it more and more now as being used as initial treatment because it's inexpensive. But you usually have to use it twice a day, but sometimes it comes in what's called gel-forming solution, and it's once a day. And there's something called istolol, which is a type of timolol. So that's a beta blocker, of which there are several. So that's a medicine that works on that trabecular meshwork and that gland which makes the fluid to help the pressure go down. There is probably the most common medicine is a drop that you use at night. I'm sorry, do you have a question? Yeah, so Travatan is in this class of medicine which is typically used as the first line treatment for glaucoma. There's something maybe you heard of called Zalatan, which has gone generic to latanoprost. You have Travatan, which is in the same class. Lumagan, and now there's one that's preservative-free called Zioptan. So there's 4 medicines in that class, and those are typically the medicines that people start on, and it's 1 drop at night. And all you need is 1 drop. It's a very strong medicine. They're a little bit pricey, the eye drops, but you should always ask for a sample, and you should always try and get a coupon from the manufacturer if you can. Some of them have coupons, some do not. And some insurances accept them, and some do not. So it's difficult to keep up on. Okay, so there's another class of medicine called brimonidine, that's a generic for medicine for alpha-GAN. It's got a purple top, right? Okay? And so that's another medicine which all lower the pressure. Brimonidine is what's called an alpha agonist, and it works on these cellular levels to help the fluid flow through that trabecular meshwork a little bit better. So the use of these drops, there are several classes of them, and some people may be on a whole store of them. 5. So some people use multiple drops, not just 1. And some people, joy, have surgery for glaucoma. And we have to do something where the drops aren't working, and I have to put this little tube or other type of surgery in the eye to lower the pressure. And that usually means you have quite advanced glaucoma. What we got now?
I have a question.
Yes, sir.
Concerning storage of these medicines.
Sure.
We keep in the house the regular medication, keep it in the bedroom.
Okay.
But we also, because of earthquake preparedness, we have some timolol out in the garage. And is there any guidelines as far as how long you can store something?
Well, okay, the question has to do with like storage of these medicines. Maybe Dale's going down to Mexico and buying a bunch. I don't know that you got a bunch of the medicines hanging around, but all the medicines, if you look at them closely, will have an expiration date on them. Okay, typically they expire after about a year. And so once they're expired, like I have a sample and it's going to expire. Typically we'll say, well, just use this one up now. You know, it's not the end of the world if it's a few weeks after or something like that, but if it's a year later, you don't want to use that. You do not want to let the drops get hot. Okay? So anybody ever here fried an egg? Yeah, everyone's fried an egg. And you know, the yolk is clear, right? But what happens when you put it on the stove? It turns white. Well, it's still the same. What happened was you changed the nature of the protein in the yolk. I mean, not the yolk, the white portion, whatever, of the egg. And so because the medicines are protein, heat can, what's called denature the protein and change its effectiveness. And it can change the way it is. So you don't, especially in an environment like this, typically want to let your drops get hot. I always tell people, don't leave them in your car, in the dashboard of your car, especially where it's, you know, it's out here. That can be very, very, very warm. And that especially goes for the medicines like you're using, Travatan, Zalatan, which is now latanoprost, Lumigan. Okay, these eye drops are susceptible to heat problems. So you don't want to necessarily store them longer than the expiration date, and you certainly don't want to let them get hot. You don't have to freeze them, or you don't have to keep them in a cold environment, just room temperature. What I was mentioning, you have such a beautiful name, but I can't pronounce it right. How do you say it again? How do you say your name again? Arloa. What I was saying to Arloa about lowering or putting the eye drops in the refrigerator, that was simply just to allow you to feel the drops on your eye. So they'll just allow you to feel the drops. But storing the drops, and that's a great idea, you know, to keep something in case of emergency with all your medicines. But you might want to keep it in, you know, not necessarily in the garage, where I assume your garage is not air conditioned up here. So glaucoma overall is a problem with your optic nerve. And your optic nerve is really even a misnomer. It's not a nerve. It's about 1.5 million little nerves which coalesce to form one nerve, which connects from your eye to your brain. And just like any other nerve problems, like a spinal cord injury, which can lead to paralysis, or if you had like a compressed disc in your back and you have sciatica and you lose sensation in your leg, that's a nerve problem. Parkinson's is a nerve problem. Alzheimer's is a nerve problem. Now, glaucoma and these other things are not necessarily related. The point is that these are all very difficult problems in that when they have damage, when there's pathology to nerves, it almost always is irreversible. Okay, like stroke. Some of you may have had strokes. Maybe you know people have had strokes. Usually they'll get a little bit back, but they don't get everything back. And so that's a nerve problem with a big old nerve, the old pumpkin up here. Okay? So just like that, when you have damage to the nerve, it is irreversible. And no matter how many drops, and if you keep them in the refrigerator or the garage, or you put them on your eye from 3 feet away, and you still get them in, the nerve won't come back. Okay? I'm going to show this cartoon again and show you just the anatomy. Front of the eye, looking at the side, the ciliary body, which is that little gland which produces that fluid. That fluid flows behind the iris. So it's flowing behind the iris, up, forward through the pupil, out of this angle where it has, and the angle has a trabecular meshwork where that fluid flows through and then gets picked up by blood vessels, and that creates a pressure in the eye. Everybody has a pressure, and I promised to tell you what normal pressure was. Well, that's a great question. What's normal? Well, what's normal? I was married once, and my wife asked me if I was normal. So I don't know what normal is. The same thing goes with eye pressure. Eye pressure, you may have heard this magic number of 21. Well, about 1955 to 58, I can't remember the exact year, in Rochester, Minnesota, the Mayo Clinic, they gathered up about 2,000 people, said, we're going to check your eye pressure. Well, number one, in 1955, at the Mayo Clinic in Rochester, you can guarantee there was not a cross-cultural group of individuals. It was very homogeneous, number one. So the point being that eye pressure can vary a little bit between different races. But they came up with a number, and they said that number is between 16 and 17 is a normal pressure. And then they said, okay, well, let's send this to the statistician. And the statistician said, well, great, well, abnormal is 2 standard deviations above that 17. And then they came up with this number 21. So they used to tell you if your pressure was higher than 21, you had glaucoma. Well, there's lots of people walking around with pressures that are higher than 21 that don't have glaucoma. And there's lots of people walking around with pressures less than 21 who do have glaucoma. So the eye pressure, which is normal, is really geared to what pressure is not causing damage to that optic nerve. Some people, and this is very prevalent in especially the Japanese population, have what's called low tension glaucoma. And those individuals will have a pressure that other people will say, hey, that's great, your pressure was 12, it was wonderful. But they have very devastating glaucoma. And it often happens in young people, you know, in their 20s and so forth. And they almost always have to have surgery if it's progressive. Some people are walking around, pressure's 28, and they don't have any glaucoma at all. There's a lot of variables that go into what's normal. One of the things I didn't mention was something called your corneal thickness, and that gets something else that gets measured in glaucoma. So there are a number of things that we look at. And those risk factors for glaucoma include eye pressure, so that's a risk factor. Age, can't change that one. It only goes in one direction as far as I know. So age goes up. So once you get up over 60, the incidence of glaucoma increases. Race, some races, Hispanics, tend to have more glaucoma and usually present with a more advanced glaucoma. African Americans tend to have more advanced glaucoma. I mentioned Japanese, they tend to have glaucoma at a different pressure, and they tend to have this narrow angle, this angle closure more often. So where were we? Race, age. Diabetes is a risk factor for glaucoma. Uncontrolled high blood pressure, risk factor for glaucoma. Family history, a risk factor for glaucoma. You're starting to look at this list and you're going, I can't really change much of that, can I? No, can't. You can keep healthy, you can keep your cardiovascular health good, keep your blood pressure good, keep your blood cholesterol well so you don't develop atherosclerosis. And then you can change your eye pressure. And so when you come in and we start you on eye drops, whether they come from the garage or they come from the refrigerator, those eye drops are going to help lower the pressure, and it's going to help decrease the damage which is occurring back on that optic nerve. And when that happens, you don't see a lick better. Your whole goal is to just break even, okay? So the whole point is to just try and keep you seeing as well as you're seeing. There are some things that we can do to try and help you see a little bit better, but mostly it's about glaucoma treatment is to help you see, keep you seeing what you're seeing. Yes, sir.
What do you think about marijuana?
What do I think about marijuana and glaucoma treatment? Yeah. Donna has her opinion over here. Marijuana has been touted as having a effect to decrease the rate of glaucoma by lowering the eye pressure. The amount of marijuana and the frequency of marijuana that you would have to smoke to get the same effect of using 1 drop of Travatan or Timolol or Brimonidine is, you know, unless you're planning on going on the reggae Rastafarian concert trail, is not very, very effective in lowering eye pressure. And the American Academy of Ophthalmology does not endorse the use of marijuana to lower the eye pressure. It's not really proven to be an effective treatment for glaucoma. So, but it is very popular advocating for the use and medicinal use in the laws which want to go ahead and, especially in California and some other states, to have what's called medical marijuana, which there is no prescription. Please don't come to me for a marijuana prescription. It's not that there's no such thing as a prescription for marijuana. You need to go to a dispensary and within a co-op and do whatever their bylaws say, but that has nothing to do with me. Yeah. Yes, ma'am.
The liquid that you're talking about is treated by these, does the excess come out through tear ducts?
No, it does not. So this fluid that we're talking about is called aqueous humor, and that fluid circulates and just stays within the eye and creates the pressure, which is kind of showing you in here in the green. And when it comes out of there, it just gets picked up by your blood vessel. It's not your tears. It is not your tears film. Okay, the tear film is something entirely different. So, glaucoma. Joy, how you doing with your glaucoma? The eye's not good. Right one and left one's good. So that can happen, and yeah. So even after, yeah. So you're experiencing a blind spot, and that is because part of that optic nerve has been damaged and can't come back. And so what we're trying to do is just keep the pressure down so that doesn't progress. I heard someone say stem cell. Everyone know what stem cells are? I don't know what the heck stem cells are. It sounds great. I don't know. It sounds like you can just go to the store and buy a new human body part. And maybe that will be true someday. But it's not true now. But stem cells have to do with is what's called a pluripotent cell that comes when cells develop at first, and in the development of any animal and person, is that these cells have the potential of growing into any other type of cell. Your whole body's cells, but your hair cells are just not quite the same as your muscle cells, are they? But they're still cells. And so at one point there was a cell which kind of said, I want to be an eyeball, and actually particularly different parts of that eyeball. And so there is stem cell research which is going on, which again has a lot of political overlay. But in the stem cells, what they are potentially doing is regrowing loss of these cells. Probably the first disease which will be approached with stem cell is Parkinson's, because that seems to be where all the focus is. There is some research going on for stem cell for the eyes, of course, and we can actually grow in new parts of those nerves. But it's a whole other trick taking that out of a petri dish, putting it in your eye, having it go from your eye, and connecting to the portion where it's supposed to go in your brain. That will probably be around, if it does come around at the twilight of my career, if not the end of my career. Yeah. Yes?
Can you describe again what happens when you use the laser surgery?
Okay, so getting away from drops and lowering the pressure, there are a couple of treatments that we do. One is called laser, called typically SLT, which stands for selective laser trabeculoplasty. And what that does is it stimulates that trabecular meshwork to make it more, a little more malleable, if you will. So you ever find an old sponge underneath your sink? It's all crinkled up and dry and kind of gross. What do you do with it first thing? Well, Gene Jonathan throws them out. But you put it in water, right? That's where my analogy is. You take it out and go, oh, jar, look at this crinkly old sponge. Put it under water and it makes that crinkly old sponge nice and flexible and malleable, and the fluid flows through it nice. Well, that's what you're doing with the laser, is you're making that sponge from a kind of crinkly old sponge into a more malleable sponge, and it does that by eliciting a chemical reaction in the cells that the lasers are targeting. And So it decreases the resistance to outflow and thereby decreasing the pressure in the eye. There are other things that are called shunts. Some people here have shunts placed in their eye for eye pressure. And they totally bypass, I put a mechanical tube, if you will. Like imagine my finger here is a tube, and it goes here, and then the fluid goes through that tube as a low resistance outflow channel, and then it goes to something which I have to sew to the back of the eye here. And that's a surgical intervention. And that usually indicates that your eye pressure is quite out of control and that your optic nerve is being damaged and the medicines are not effective, and so forth. Well, it can affect the sight and it doesn't make you see better. Yeah, it doesn't make you see better. It's not like cataract surgery. You can discuss a little bit about cataracts in a moment. All it does is try to keep the sight that you have. But even doing the surgery, if you have quite advanced glaucoma, doing the surgery, if you approach it very late, some people lose some vision after the surgery, just from the surgery. Okay, and that's what the lady right behind you was describing. There's not a hormone that disperses the fluid. No, it's not a hormone. I know. Sorry. I'm gonna shift gears here a little bit, and why don't we clear these guys here, and why don't we go here? Anybody here have ever had cataract surgery? I'm sure I didn't look up because I'm probably sure in this age group, probably about 100% of the hands went up. Do you know what the heck happened? Or did they just say, come on in and let me take that cataract out? Okay. What happened? Well, let me just talk a little bit about what cataracts are. Cataracts are a different story. It has a little bit of a much more kind of happy ending, so if you will. So here we are again with the eye, and now we're going to focus on that thing that lit up there called the lens. Let me go back. That happened kind of quick. So here's the eye. Pause this. So in the eye, your front of the eye, the back of the eye, there's that optic nerve we were talking about in glaucoma, gets damaged. There's this structure here called the lens. The lens can get cloudy with time. It's a birthday present, okay? And every year you have a birthday and you get some presents you might not want. I had a patient come in a week or two ago, and he said, when I was young, things came and went. As I got older, things came and stayed. So this is one of the things that come and stays. And so the lens is a cell, just like all those other cells we were talking about. And the lens grows. Ever since you were a little child, that lens has been growing layer upon layer upon layer, like an onion or a tree. And its ability to maintain clarity goes down. And when you see the light, I don't know if you can see this red light comes forward and goes through the pupil, and it goes through that lens, and it needs to focus back here on the retina, like a camera. So this is like the lens of your camera. And this is like well, we don't have film in our cameras anymore, do we? But this is like the film of your camera, okay? And so if this thing gets cloudy, then the pictures you're taking start to get hazy. Or you're driving at night and things are bright and you get a lot of glare and so forth. And so what we do is, that's called a cataract. Cataracts do not cause permanent vision loss like damage to the optic nerve, because it is simply a cloudy lens. And the lens is removed with surgery. It takes about 25 minutes to do. And for the vast majority of cases, people do very, very well after cataract surgery, where we remove that lens. And so that's lining up where the lens is. And so here's this lens in the eye, behind the iris. And right here, so that light comes through and focuses on the retina, and then gets sent by the optic nerve in a normal situation. Well, let's show that lens get a little cloudy here now. And like one of the symptoms of that lens, see how it's kind of getting darker? I don't know if you can appreciate that. It's getting a little darker and darker and darker. And so when the light comes through, I can still read the Daily Times, but boy, my HD TV is not looking so HD anymore, okay? And so you start to get symptoms where things are just a little bit blurry, headlights coming at you like this, a little bit of glare. And what are they talking about here? Cataracts. Okay, so we do it. And we make an incision and we remove the lens. And the lens, come on, cartoon, is again here. We do this in the operating room, not in the office. We make well, they're showing quite a large incision. We make a very tiny incision. It's about 2.5 millimeters. And we do it through the cornea, and so it doesn't bleed and it doesn't need stitches or anything. We used to do cataract in a much different way, where you need a lot of stitches and you'd be in a hospital, all this business, all those days are long gone. You come in, we use an instrument which breaks the lens up into a liquid, okay? And it breaks the crystalline lens up into a liquid, and it is manipulated, and we remove all the lens. And then, if we didn't put a man-made lens in its place, you'd see really poorly. And so what we have to do is put a man-made lens in, which just looks like this. It's kind of clear, so you don't know if you can appreciate that. But it's got these little arms, and it folds and goes through a very tiny, tiny incision, which then we place in the eye, behind the iris. It sits in place. It's not sutured typically to the eye. And it just sits in place and stays there, and now you have a clear lens in your eye. Give me 1 second. And that is called phacoemulsification. It is by far the most common eye surgery that is done, and probably, I didn't see all the hands went up, but I would assume that almost 90% of the people in the room here have had cataract surgery, at least on one eye. I got one question to Heavy Harry. What's that?
I just wanted to ask.
Yes.
When you decide, when you decide to do the surgery, because I've been told I have cataract and I'm seeing less in my right eye. They're saying it's not time yet. When is the time?
Yeah, that's a great question. Well, cataract surgery is elective, meaning that you're not going to go blind from cataracts. Your vision will get more and more blurry, but you're not going to lose something by not doing cataract surgery today and then doing it next month or next year. You're not having irreversible loss of vision from cataract. So when is it time? It's time, and you said, well, when the doctor decides. Well, typically what I do is I reverse that around. As long as you have a cataract there, I say, how are you doing? You say, oh, I'm doing fine. I'm driving. I passed my driver's license test, and I can see everything. I'm playing cards, and I'm golfing, and, you know. So I say, well, I don't necessarily think you need cataract surgery. Your vision may be not that great, but you're doing what you need to do, and you're functioning. So why do a surgery unless you need it? Because while it is a very successful and quick surgery, the old adage is minor surgeries, surgery on somebody else, you know, not on me. So I turn it around and say, well, how are you doing with your symptoms? Well, if you're telling me I can't pass my driver's license test, or I can't play cards, or I can't golf, or I can't do that, and it looks like it's coming from cataract, not from something else, then it's time to do cataract surgery.
And it causes eye strain to be constantly trying to see better with that eye than you're able to.
What the question is about eye strain, and if cataracts cause eye strain. Well, eye strain is not really a medical condition, but I understand what you're saying. It's like your eye's tired. Yes, it can make your eye tired, but it does not cause damage to your eye, and it will make your activities. And usually, typically, what we do is we say, well, you know, you have a cataract here. How are you doing? And if the answer is, hey, I'm doing great, then why do a surgery? Unless it's causing an irreversible problem, I would always kind of turn it around and ask you how you're doing. And so some people will have vision which is not as bad. I don't know how your vision is, but it may not be as bad as you, but you know, I can't see that golf ball anymore. And guess what I do at 6:30 in the morning, 5 days a week, and I'm meeting my buddies, and that's important, right? So cataract surgery is more important. I'm talking to somebody who's 94 and lives in Sun City and has all their stuff delivered to them and doesn't need to drive and is happy as can be, and their vision is 5 times worse than that golfing fella. How you doing, man? Well, I'm doing fine. You don't need cataract surgery then, unless you want it. If you want it, then we'll do that and provide the service. But it's an elective surgery, so the decision is not one way. It's not me saying you need surgery. It's me saying you have a cataract, and I think your vision would improve with cataract surgery. How are you doing? And then you tell me, and then we decide what you want to do. I saw a hand go up, 1 second, Joy. I saw a hand come up over here. It was kind of tentative and went up and went down. I don't know who was that. Well, here it was.
At what point is surgery not going to help?
Cataract surgery will almost always help as long as you don't have other problems with the eye. Okay. Yeah, so some people may have very advanced macular degeneration, or they may have very advanced glaucoma. Cataract surgery will still improve their vision some, but very often until the time it's going to still have that other pathology which is limiting your vision in somehow. But cataract surgery can almost always be performed on an eye and give you some improvement, but not always. But it's in an individual basis. Yeah. The question has to do if you have advanced macular, and I assume you mean macular degeneration, surgery. Will cataract surgery help? It can. If your cataract is significant enough and your macular degeneration is causing you loss of your central vision, cataract surgery can help brighten what you are still remaining seeing, but it will not give you back any vision loss that is coming from the macular degeneration. It shouldn't make macular degeneration any worse, and actually may help your macular degeneration treatment, because anybody here have macular degeneration they get injections for, shots in the eye for? I see a couple hands going up, so a couple hands going up where you get Avastin or Lucentis, and you see one of our retina specialists in town, which we have several very good retina specialists now available to us here in the Valley. And so they, so even if you have macular degeneration, yes, you can have cataract surgery and have an improvement. The amount of improvement has to do with how much macular degeneration you have. But almost always you're going to get some improvement, assuming that the cataract is significant enough. Well, Joy, yes, what's up? Yes. Okay. Okay. Right. Well, kind of what it does is it kind of comes back to the same answer like you had mentioned there. So if that loss of vision you have is coming from the glaucoma, which I know you enjoy, and a lot of that loss that you have is coming from glaucoma, but some of it is also coming from the cataract. It's hard for us to predict, but you should get some improvement in your vision, certainly with the cataract removal. But it's not going to take away anything that was lost from the glaucoma. Yeah. Well, yes, I hope it does, but it will not improve anything that's coming from the glaucoma, just from the cataract. We got one over here. Yes. Hi. What's your name?
Sandy Serino.
Hi, Sandy Serino. Was that with a C, Serino?
It's with an S.
It's with an S. Okay, so more Italian than Greek.
You and I have met under surgical procedures.
Okay.
May I ask a question about a different affliction?
A different what?
Affliction.
Oh, a different medical problem. Yes. Okay.
Could you explain to me what physically happens with the eye that you can no longer see in dim light, those of us that can't drive at night any longer?
Well, okay. The question has to do with night vision, and it's poor, and typically there's not going to be one thing that's doing that. There could be several things. You could have advanced glaucoma. You could have advanced macular degeneration. You could have bad cataract. There are many eye problems, and so almost anything that is eye damaging the eye, can affect your vision, and it oftentimes is worse at night. The reason is because your eye dilates at night, and it lets in more stray light, and it just makes it more challenging. So that's not one particular affliction, as you say, but very commonly things that we see that are affecting that are macular degeneration, glaucoma, cataracts. Some people have corneal problems, which are a unique problem also. So there are several things which can affect your vision, and oftentimes vision loss that is from one or multiple of these problems does get worse at night, simply because night vision is more challenging as your pupil dilates and there's less ambient light. Okay. Start using flashlights. Okay, there we go. Well, all right. Anybody here have macular degeneration? I know I saw a couple arms, hands go up there. Let me see what I got here. There's wet and there's dry. I hear the crowd gearing up here. Let me just clear these guys here, and I'm going to go over here to macular. Macular degeneration. All right, let's play some of these and see what they look like. Let me just make sure this comes up again. Okay, Donna, what was that? Did you have a question, Donna? Oh, yeah. Yes? Right.
There is the low vision center, and you know here is familiar with it. They have an office in Riverside, San Diego, and LA. And if there is a device that can help me see at night or just see, they have it.
Okay.
And what I have, well, one of the many problems with seeing at night, is there are glasses that, I don't know, they have like a polarized lens or whatever, that
Right.
cuts down the glare at night without cutting down the light.
Okay.
Because a lot of times at night you have glare, but you put like a darker lens and you also cut down the light, which is dangerous. And this was, I mean, it just was.
It helped you out a lot.
It was so good in helping me out, especially when I came to the desert, it was so dark here.
Right.
She's been able to drive at night. She not really wanting to drive at night.
So what we're describing is polarization, and you can get that on your glasses, but they don't have to necessarily be sunglasses. And what polarization is it just, there are these tiny little slits in the, not physical slits, but slits in the grounding of the glass, and this decreases glare by only allowing light to come in at one, like a picket fence. So imagine a picket fence, and if you want to go through that picket fence, well, you can go through it this way, but try going through it sideways. Well, light is trying to come through at all different angles, like this, that, but it only allows the light to come through one way, and so it decreases glare, and not necessarily with sunglasses. So if you do want to get sunglasses or just regular glasses with polarized glass, it's called polarized, that can help reduce glare. I mean, I see this lady has them on right there, so I can tell them from right on there. So, was there a question over here? Oh yeah, what you got?
I just have one more question.
Yeah.
On the cataracts.
Yes, ma'am.
Do you have cataract surgery? Do you then have to get a new prescription for glasses?
Definitely, cataract surgery will change your refractive error. So this gentleman over here was asking me about cataract surgery. I thought he was going to ask about himself because he's very nearsighted. I can tell from across the room with those glasses that he's got on. And so yes, if he had cataract surgery, or anyone has cataract surgery, if you have glasses, oftentimes there's a discussion about the lens that's placed in the eye and what we want to achieve after cataract surgery. Often we want to try and achieve so your distance vision is minimally affected and needs very little in the way of glasses, but oftentimes you'll need reading glasses. And add on to that point is you may have heard about what are called multifocal lenses, and that's a little bit more of a conversation which would be individually kind of discussed about what's called a multifocal lens in cataract surgery. There are several different points about that, but yes, your glasses almost always change. Medicare has a benefit that when you get your cataract surgery, you get a kind of a set of glasses after cataract surgery and paid for. That's kind of, that law has kind of changed back and forth over the last couple of years. But, yeah. Yes.
Well, I want to say, these glasses, they don't seem clear to me. I don't, is there a better glass? They don't, I don't even want to wear them.
Okay.
It's like when I take them off, it seems clear.
Okay, well, I don't know if the prescription is correct, but
The lens itself doesn't seem.
yeah, it's not that the lens just from here look pretty clear. Unfortunately, again, I know what your back of your eye looks like. You have very significant glaucoma, which is affecting your vision also. So no glasses are going to improve your vision from glaucoma. So.
It just seems like that. I mean, isn't there different grades of glasses you get?
No, it's not. It's just you have to have a prescription that is right for you, and also it's only going to work as well as the potential of the vision of your eye. And I know, Joy, that you're. Yeah.
They say that there's a lens.
Yeah, I know.
One over here you can see better.
Yeah, I know. I mean, I saw an advertisement that says if I use this detergent, it'll make my socks whiter, and this one. So the point being is that you have other things going on, and I don't know how to make the claims from the glasses, but yes, glasses do come in different quality and so forth, and that's the kind of discussion with whoever you have the glasses made from. But just again, I know what the back of your eye looks like, and I know that you're limited in vision, which is very unlikely to be improved with whatever grade of glass you get. Okay? Yes.
Do any of these eye problems, are they the reason for pain in the eyeball?
Some of these problems can cause pain in the eye. Yeah. Okay? Which ones? Well, typically glaucoma is not painful, unless you get this one where I said the pressure goes way up with angle closure glaucoma. But typically glaucoma is not painful. Macular degeneration, not painful. Typically what's painful is when you start to get problems with the surface of your eye, with like allergies and tearing and dry eye. Some people may have had shingles and get them in their eye. That's a very difficult problem. It leads to long-term. I don't know if any of you had shingles, but sometimes it affects the shingles goes into your eye, and that's a very painful, difficult problem. It does affect the eye tremendously. So the eye pain typically is something with the surface of the eye and can be reduced with the use of some artificial tears. But you may be having some problems with the skin around the eye and the glands, the eyelids, and that's a problem called blepharitis, which is often very painful. Something that is also very common, which is kind of goes hand in hand with blepharitis, is something called rosacea. I don't know if you've heard of that, which is a kind of a skin problem, but does affect the glands, which help make better tears. But eye pain is usually a surface problem, not one of these internal, like cataract is painless, macular degeneration painless, glaucoma almost always painless, painless problems. So eye pain might be something to do with that, with a surface problem. Okay. Yeah. Okay, well, that, so a throbbing pain which lasts a couple of seconds, is that what you're saying? Okay, that's what I call a fascinoma. I mean, it's fascinating, but I don't know what it is. But typically that doesn't cause vision loss. It is not a problem, but you may consider using some of the Systane drops or something just to lubricate. You might just be having a little bit of dry spots on the eye. I had a question someplace over here. Hello.
What is the laser binding and the treatment for glaucoma?
Oh, the treatment for glaucoma?
Okay, that's, they say in the seminar before to read the binding and the latest.
Well, what we were talking about for the treatment for glaucoma almost always...
Decided
almost always starts with eye drops.
Okay.
And then we kind of mentioned this laser when we were talking about making the sponge a little less hard. And then there's that tube shunt where I was kind of showing you my hand there. There's this shunt, the surgical intervention that we do. So those are the typical treatment modalities. Now there are several different types of surgeries. The individual surgeries all try to accomplish the same thing into lowering the pressure. Most commonly there's something called trabeculectomy, and then there's something called an aqueous shunt. You may have heard of something called canaloplasty, which is not very popular and has not been a very successful surgery to do. There is now there's something Glaucoma shunt that is also placed in the eye. Other surgical intervention, there's something called trabectome, which we have available here. It's okay. It's not the greatest in treatments. Well, they're all just to lower the pressure, to work on the trabecular meshwork to try and lower the intraocular pressure. Trabectome is a relatively new, in the last 5-6 years, treatment. Don Winkler and I was involved a little bit with that down at UC Irvine, kind of came up with that. It's not, I don't find trabectome to be the greatest procedure, but it works some. There's something called cyclophotocoagulation, which you can either do it through the outside of the eye, or I put this little camera inside the eye, which has a laser attached to it. That, unfortunately, is not available in the desert. I would have to bring it to the Beverly Hills office for that. That's not commonly available. I got a question from, I'm sorry, what was it again?
Oh,
Yeah.
I'm Annie.
Annie.
I had closed angle glaucoma.
Okay.
I had 2 iridotomies.
Okay.
I had a lens replacement, like cataract surgery.
Okay.
One question I have is, why is it so hard to diagnose? Because it took 3 years to figure out what was wrong with me.
Okay.
And number 2, my question is, what is the long-term effect of closed angle, even though I had the surgery? And number 3, why don't they use iridotomies on regular glaucoma?
Okay, well, that has to go back to that angle anatomy that we talked about. When you have angle closure, did you have it doesn't sound like you had acute angle closure,
Yeah.
because, okay, you're throwing up, your eye was in,
70, oh yeah.
okay, so you had acute angle closure glaucoma, which is,
Dr. Schaff and I were running through Eisenhower.
yeah, okay, yeah, so acute angle closure glaucoma is a true emergency when that angle closes off and you have to do treatment right away, either surgical or laser.
Yeah,
Yeah.
24 hours.
Yeah. So what that is that's a treatment that it has to be acutely done to open up the angle. But that is not what the problem is in open angle glaucoma. By nature, one's open, one's closed. All you're doing when you do the treatment for angle closure is opening the angle. So people who have angle closure usually have to have what you described as an iridotomy. Why it was difficult to diagnose? I mean, I don't know. I mean, I don't exactly know how to respond to that.
3 years, and I'm just always surprised that the symptoms are more like acute migraine,
Yeah.
and then the blindness and all that.
Right. Well, acute angle closure glaucoma is something that oftentimes I see people who get referred to me and they say, hey, Dr. Schofield, what does this person need a laser preventatively for angle closure glaucoma so they don't get the angle closure, and because the angles are kind of narrow? And I look at them and I say, yeah, this person's angle looks like it could occlude, or I say, well, this doesn't look like it could occlude, but we'll watch it. And but we do a preventative laser, which is a lot easier to do than running through Eisenhower with a headache and throwing up. So I try to do them in a preventative nature. But sometimes people just don't know, and that happens. And then you need treatment. What you got?
What causes double vision? Is it an age thing?
Double vision is caused by a lot of things. So it can be pretty much refractive error. It could be you have crossed eyes. You can have other problems with the eyes. Thank you. Sensitivity to light. Again, a lot of these problems can cause sensitivity to light. Cataracts, glaucoma, macular degeneration, all of these things are are something that can do that. But yes.
So the bottom line is glaucoma is you don't know what causes it. I mean, it's not a dietary thing.
Well, what causes glaucoma, or what the problem with glaucoma is a problem with the optic nerve. And some people's optic nerves are more susceptible to damage. And that damage can come from eye pressure, and oftentimes is what is the cause. But there can be other...
We don't know what causes that pressure to build up. I mean, you're talking about treatments and surgeries.
No. What I'm saying is what causes that pressure to build up is that angle that we mentioned that has that trabecular meshwork in it, and some people's that membrane, that tissue doesn't work as well, and the pressure goes up. Okay, but some people's optic nerves aren't as susceptible, so they won't get damaged. Almost everybody's optic nerve will start to get damaged after a pressure of about 30. And that's a risk factor. Family history is right. Oh, right. So, yes, what do you got here?
Is it true that wearing sunglasses will help prevent
The question that just came to me from Winnie here was, will sunglasses decrease the rate of macular degeneration or the prevention of macular degeneration? Yeah. There is some evidence that shows that certain wavelengths of light can accelerate macular degeneration. But the overwhelming, the big gorilla in the room about macular degeneration is your family history and how old you are. Because it's really called age-related macular degeneration. So I may have mentioned earlier that every year you have a birthday and every year you get presents. And some people get presents they don't want. Some presents you can give back, like the cataract. I can say, let's return that sucker and get it out of here and get you seeing better. Macular degeneration is a problem where your macula, the retina, and I'm going to describe that right here with this here, starts to degenerate in the macula. The macula is the center portion. So imagine you had this map of the United States, and you went to the center. It's probably someplace in Kansas or Oklahoma or someplace, right? So the macula is center right there in your center of your retina, but that whole map of the United States is your retina, okay? So think about it like this. This is how I describe it. I'm sorry, what was your name again? What was your name again? Jim? Oh, Jim. Okay, so I'm looking at Jim. You're Jim, right? Okay, I'm looking at Jim, and his wife, what's your name? Liz. Well, Liz knows if Jim's paying attention to her not at dinner or looking at the waitress is delivering the drinks, because she can tell he's looking right at me, or maybe he's looking just a little bit off, focused on what he's looking at. I can see Jim over there, but I'm looking at Joy, and was it Helen? Is this the Helen trio back here? Okay. But now I'm looking at Helen, but I can see Joy. Now Joy is focusing on my retina, but not focusing on the center macula of my eye. Okay, so I'm looking right here at Winnie, but I know Donna's over there, and I can see her. I can see if she waves to me, but it's not clear. And so that clear portion is my macula, the center portion of the retina. The rest of the retina works, but it doesn't work as sharply as the macula. And when macula degenerates, it takes away that center crisp vision and leaves you with some peripheral vision. It almost never causes complete blindness. Glaucoma can cause complete blindness. Macular degeneration will take away that center like a smudge in your vision, like boom, like somebody put a thumbprint right in what I'm seeing. Donnie, you have a question?
Well, I thought it said macular degeneration kills the acuity, and the glaucoma kills your peripheral.
Right, yeah, some people have both macular degeneration, which will take away the center vision. Okay, here we go. And center vision, and they have glaucoma too, and so it takes away your vision. Afuera. So it takes away your outside vision, okay? And so you got that burning at both ends of the candle. So some things, when I was younger, some things came and went. As I got older, some things came and stayed. So Teddy, who is kind enough to work with me here, said something this morning. We had a little coffee at my place over here beforehand. So he said, we're going to go to the Braille Institute. And what did you say, Teddy?
I have no idea.
You said no one gets out of this thing alive, so enjoy it while you got it, and so forth. And that's true, but we will also, as physicians in medical treatment, try and keep you seeing. But you know what? I went to medical school. I didn't go to God school. Some of these problems are we can control, but I can't do certain things. We just don't do that. I'm going to play a little bit of this macular degeneration because I think this is common here. So did we see where we were there? Let me just rewind that. Play it. That's the eye, the front, obviously. We're going to go through the pupil to the retina, that back surface of the eye. No, what was that? What was that thing? That's the optic nerve. That's the guy that gets damaged in glaucoma. So your problem with glaucoma is when that guy gets damaged. But now we're going to shift over to here, this area. This pointer doesn't work so well. This area right here in the center part of your retina. So your retina is the whole big orange thing, but the very center of it, just like the map of the United States. Imagine this in the United States, Kansas is right in the middle. And that's what we call the macula. And when that macula gets damaged, your central vision goes off. And remember, that's the vision where I can say, okay, I'm looking here, but I can still see here, but my sharp vision's on you. And now, because I'm putting that image of Jim there right on my macula. And so that's what gets damaged. And so that's called macular degeneration. And what you'll see is all of a sudden the macula, which is highlighted there, they'll get these little things, little yellow spots. We call those gray hairs of the retina. Okay? The retina gets a little older and it gets drusen. It's a funny word, but it's actually a metabolic byproduct of the retina. And it starts to build up. And almost everyone will get some drusen in their eye. Okay? You have a birthday, you get presents. This is a present. Now, it doesn't necessarily mean it's going to affect your vision. Almost everyone has some drusen on their eye, in their macula, as a byproduct just from aging. But it doesn't necessarily mean it affects your vision. But oftentimes that drusen will build up, build up, build up, and then it will affect your vision in that central portion. So what we're showing here is that retina. Now, what gets affected in macular degeneration is that center vision, okay? We're looking at Kitchen Sales and Associates. I don't know what that is. And give me a second, I don't know where it's going here. But it'll start to affect your reading vision, your ability to see things up in the center of your vision. Notice the outside of the vision was fine, but that center vision not only got a little dark, but also got a little wavy. Funny word for that, Harry, is called metamorphopsia. And then eventually it'll become a black spot. But typically that's because that center vision is affected. But you can see out here, but it typically won't go to the whole retina. It just affects that center portion. However, that part that lets you see clear. Okay. Now, I heard somebody, as soon as I said macular degeneration, said, wet and dry. Oh boy, wet and dry. Who said that? Was that you? Oh, okay. Wet and dry macular degeneration. Well, what's the difference? Well, what you saw there was, this is symptoms again. What you saw there was this drusen, and that's typically the dry macular degeneration, much more common than wet macular degeneration. And it's just as that macula starts to degeneration, but there's no abnormal blood flow, okay? And then what happens is people will start to, this is more symptoms of the macular degeneration, that wavy lines and a smudgy spot. What happens is that that center portion will stay there and keep you from reading. This is the symptoms again. And this can be dry or wet macular degeneration. The dry means that you just have those drusen and they built up so much that it degenerated that retina. What the wet means is that the blood vessels on the retina start to grow abnormally and they're bleeding in the eye. And then that's what the wet is. The wet is blood. And then you need treatments. Yeah, okay, you got questions on that. All right, let me get to this one's going to go to the wet form of macular degeneration, right? This one's, is it just going to keep playing the dry here? Okay, so here we have on the retina, this is the macula, that center portion, and about 90% of the people they're telling us have this dry form of macular degeneration, where these cells start to break down and leave these byproducts called drusen on the retina. That's this yellow little guy here. That's the, okay? And they just build up and they affect your vision. But again, what can happen, sometimes those blood vessels which are down here can break through and cause bleeding and then cause wet macular degeneration. What they're describing here is this buildup of drusen. This is at the microscopic level of your retina. And those yellow deposits, okay? Those are the gray hairs of the retina, if you will. And it causes this type of damage. What eventually can happen, which is going to come up, I think, on the next little cartoon, okay, is that dry macular degeneration can become wet. And then that's when the bleeding starts to come through here. And that's what's going to show you in just one moment. Dry macular degeneration can be treated typically with not smoking and with some vitamins. I'll go over that in just a minute, but we're going to talk about now this wet macular degeneration, where we're talking about, okay, this 10%, that 10% of people with macular degeneration will get that bleeding. So in the retina, in that portion, all of a sudden, see these blood vessels starting to grow up from inside the retina. They start to grow abnormally. And then they start to bleed into the retina. And when that happens, now we have wet macular degeneration. And the treatment is much different. We'll go over that in just a second. And so that bleeding of the macula and the degeneration associated tends to be a little bit more aggressive. So 90% of the people have the dry macular degeneration. About 10% will get the wet macular degeneration. And the treatment options that you have for the two are different. So with dry macular degeneration, anybody here ever heard of eye vitamins? Sure, you hear about them. Eye vitamins. Somebody here takes them every day, twice a day. Preservision, Ocuvite, something like that. Preservision. Vitamins are the treatment of choice for dry macular degeneration. You should ask, though, because they're probably not inexpensive, and you got to take 4 tablets a day, probably 2 in the morning, 2 in the afternoon, or you got the big one. Yeah, so you got one big one twice a day. And so that dry macular degeneration with the vitamins comes from a study called the AREDS study. Okay, what do you got there? Age-related eye disease. Somebody was paying attention. Age-related eye disease study, AREDS study, and that's where this formulation of vitamins that were looked at can help certain people with dry macular degeneration from progressing. If you have just a little bit of macular degeneration, I typically say, you don't need to spend all your money on Preservision and Ocuvite. Just use a multivitamin and you'll be fine, and don't smoke. And don't live to be 120. Okay. But if you have a subset of dry macular degenerations do benefit, the intermediate dry macular degeneration patients do benefit from the AREDS, Preservision or Ocuvite. If you are a smoker, you cannot take that AREDS formulation of vitamins with beta-carotene in it, because the amount of beta-carotene in it in association with active smoking, not smoking that you quit 20 years ago, active smoking dramatically increases the conversion to what's called small cell carcinoma of the lung. So there is a formulation of macular degeneration vitamins which do not have beta-carotene in it for the smoker. Well, let me tell you, the best thing you can do is not even take those vitamins if you're a smoker and you don't want macular degeneration. The best thing to do is not to smoke, because smoking is a huge risk factor. The biggest is family history, age. So what do we do when we get to that wet macular degeneration? Well, what do? You tell us. You're the one doing it. Remember I said you guys are doing all the hard work, not me. Yeah, somebody comes along and smacks you. Yeah. Right. This is a great question. And what this question has to do, and I think we're going to kind of finish up with this, and then we'll just kind of do a little meet and greet because we're getting towards the end of the time here, has to do with the treatment of wet macular degeneration, which has been around now for about 6 to 7 years, of something called Avastin or Lucentis, and these are injections that are injected into the eye and typically are done in a series of multiple injections. And what the injection is a medicine which is made by a company in San Francisco called Gentech, and it's called a vascular endothelial growth factor inhibitor. VEGF, you got that one too, right? Okay. So vascular endothelial growth factor inhibitor. Basically what that injection does is it tells those blood vessels that are growing abnormally, it blocks the chemical signal at the molecular level to stop doing that. Okay? So it says, hey, stop doing that. So, but you need multiple of them. It doesn't last forever. There used to be treatments. I don't know if anyone ever got a laser treatment for macular degeneration here. We don't really do that so much more anymore. We used to give you an injection of medicine and then put a laser in front of you, and then you couldn't go outside for like 3 days or else you get a massive sunburn, and that's called photodynamic therapy. The treatment with that's bygone. The treatment now is with either Avastin or Lucentis, and they are injections, and you need a multiple injections, and then they space them out. Usually it's like every 2, 3, 4 weeks at first, so you get like until you get like 5 of them in, and then they start to cut back, and then they look for bleeding, and then they give you more. So, but it won't damage your eye. I mean, to have those done. There are some risks from doing the injections, but they typically are very well tolerated. Many of those injections are done every single day successfully. That's right.
You need a reference to Drusen, and I don't know. Can you spell that for me?
Drusen. And those are those yellow spots that grew up on there. I call those gray hairs of the retina. You got it right. Hey, all right. We got something right here today. Well, okay, what do we got?
My mother had wet macular degeneration, and she had her cataract surgery where a bubble was put in her eye, and she had to have her head down like for 3 months.
Okay. What your mother had, she may have had macular degeneration, but what she had with that surgery that you're describing, which is called a vitrectomy and a gas fluid exchange, is for someone who's had a retinal detachment. So she had a retinal detachment. Macular degeneration, if you just have macular degeneration, that is not the treatment for it. So she may have had macular degeneration, but then also had a retinal detachment, which is another story, and is not painful. Doesn't that sound awful to have your retina detached? But it's not painful. So, so that's with that. Well, my name's Dr. John Schofield. I know some of you for many years out here. I appreciate you coming out and meeting us. And bye-bye. And seeing, and you, by all means, if you'd like to talk to Sherry and Teddy or myself here, we're going to be milling around for a little bit, but we're going to go run clinic over here. 1 o'clock? Hi, 1 o'clock? Okay. What time's clinic start? At 1:30. So we got some time. We're going to run our clinic for the afternoon and finish up this lovely week out here in the beautiful Coachella Valley. And I'm really happy to be out here. Some of you know me from the Beverly Hills office, and but we're very happy to be providing this service for glaucoma and cataract surgery out here in the desert. So thank you so much for coming out.
Thank you, Dr. Schofield. We really appreciate you being here. Before you leave, just a couple of things. I'd like to thank you for being here at the Braille Institute and supporting the Institute, which allows us to offer these free seminars. Also, on your chairs are evaluation forms, so please fill those out and drop them off at the table. And Dr. Schofield has left cards at the table as well, so if you'd like a card, please pick one up. And thank you again for being here.